A very good morning to all of you. Today I'll be speaking to you on some management aspects of acute coronary syndromes. Now don't worry about the rest of the topic that I have put up. I'll be speaking only of the management before cath lab intervention. Now first part, introduction and general management of acute coronary syndromes. We start with the spectrum of myocardial ischemia, and we have a whole host of diseases of myocardial ischemia, from stable angina to sudden cardiac death. Now, if you exclude stable angina, all the other syndromes that are listed in this slide are classified under acute coronary syndrome. Now, the spectrum of myocardial ischemia, if you consider the angioscopy findings, please see the last line. In acute coronary syndromes, non-ST elevation myocardial infarction, you see a white clot. That is because the clot is platelet rich. And in ST elevation myocardial infarction, you find a red clot because it is fibrin rich, in which the red cells are entrapped. If you look at the activated platelets, again look at the last line. In non-ST elevation myocardial infarction, 70 to 80% of the platelets are activated, whereas in ST elevation myocardial infarction, 80 to 90% are activated. In acute coronary syndromes and stable angina, the activated platelets is only 5%. Now, this indicates to you that the pathophysiology of acute coronary syndromes is different for the ST elevation, non-ST elevation, as compared to the stable ischemic syndromes. Now, if you classify the acute coronary syndromes, any syndrome which is classifiable under acute myocardial infarction or unstable angina becomes an acute coronary syndrome. And the following are included: the STEMI, the non-STEMI, enzyme diagnosed myocardial infarction where the CPK or the SGOT-PT or the LDH goes up, the biomarker diagnosed myocardial infarction where the troponins go up, the late ECG diagnosed myocardial infarction where initially the myocardial infarction is not manifested, but later on the Q waves and the ST changes occur, and then unstable angina. Now, as soon as the patient presents, the diagnosis would be probable acute coronary syndrome if the clinical findings are suggestive before the ECG is done. So the level 1, as you do the ECG, you classify acute coronary syndromes into ST elevation and non-ST elevation myocardial infarction. Now, level 2, where you have the troponins also brought in, the ST elevation myocardial infarction becomes either STEMI or Prince-Mettels angina due to coronary artery spasm, and the non-ST elevation myocardial elevation acute coronary syndrome becomes either a non-STEMI or unstable angina. At level 3, which we diagnose a few days later, some develop Q waves, some do not develop Q waves, and some even normalize. Now, two management streams go hand in hand: the general management and the decision and the implementation of specific reproduction strategies for acute coronary syndromes. General management of the AMI, I will not go into details for lack of time. Try to insert 2 IV lines, especially in large infarctions, because if complications are likely, you need 2 IV lines going in, and they must be as close to the heart as possible in the upper limbs, because the drugs take a longer time to reach the heart in acute coronary syndromes with circulatory collapse. Now, oxygen. It is offered commonly to all patients with acute coronary syndromes, but this guideline has been changed. You check the pulse oximetry. If the saturation is below 90%, oxygen is indicated, but we have problems. We do not routinely administer supplemental oxygen at present. The arterial blood gas must be low, and it is suggested only that patients with ongoing chest pain, patients with heart failure should be given this oxygen. Why is that? That is because recent studies have shown increased mortality and reduced coronary flow with widespread oxygen use in the population of acute coronary syndromes. This is because of the vasospasm that hyperoxygen therapy might cause. Now, the guidelines refer to SaO2, that is arterial oxygen saturation, but in clinical practice, we act on SpO2, which we get on the pulse oximetry, because the SaO2 is not possible. It is now accepted that the guidelines which say SaO2, we can substitute SpO2 in our clinical management. Now, when it comes to pain relief, morphine is the drug of choice. and we will not go into the details of the administration, but we have some certain problems. Now, morphine leads to venodilatation and decrease in the preload, which is good, but it is detrimental in the setting of right ventricular myocardial infarction. And in right ventricular myocardial infarction, morphine administration may lead to a cardiogenic shock syndrome, and therefore it should be used with caution. If morphine cannot be given, the best analgesic is nitrous oxide mixture, 50% oxygen with 60% nitrous oxide. The NSAIDs and COX-2 inhibitors, as you know, should not ever be given. Now, we have a problem with morphine. Morphine may slow the intestinal absorption of oral antiplatelet agents. Therefore, if morphine is administered, the use of ticagrelor and clopidogrel may be retarded, and therefore morphine is not given unless very, very urgent in acute coronary syndromes in the present. It is not certainly administered routinely because it mitigates the action of the antiplatelet agents. Now, nitrates are more effective than sublingual nitrates for symptom relief. It has no prognostic benefit. Therefore, nitrates nowadays will be administered only for the control of blood pressure. Take a history, whether the patient has been on phosphodiesterase type 5 inhibitors, sildenafil or tadalafil, within the past 24 hours, because nitrates can cause life-threatening hypotension in this situation. Now, nitroglycerine is a vasodilator, and we expect that it will increase the heart rate. But it is known by a basal reflex that nitrates can cause a bradycardia. Therefore, if the patient has a complete heart block or any degree of heart block, or even a sinus bradycardia, nitrates must not be administered intravenously unless monitoring is possible. Now, the antiplatelet agents and anticoagulants are very important because, as the slide I showed you initially, the activated platelets are very high, over 80 to 90% in acute coronary syndromes. Now, aspirin is given, and it is given chewed. The current OASIS 7 study failed to find merit of giving 325 milligrams of aspirin compared to 81. Therefore, we generally come to a compromise and we administer 150 milligrams in the acute phase. If the patient is aspirin naive, that is, the patient has not been on aspirin, then 300 milligrams as an initial dose is acceptable. You do not give enter-decoded aspirin, even if the enter-decoded tablet is available. It should be chewed and swallowed with a little water, as given in the OASIS trials. Now, the contraindications for acute administration of aspirin, of course, peptic ulcer bleeding, active peptic ulcer, true aspirin allergy, not gastritis, not flatulence. And the platelet count should be about 20,000. Now, this is a problem in certain dengue patients, where patients with low platelet counts may develop a myocardial infarction due to some other reason. And then we wonder whether we can administer aspirin. The contraindication level given is 20,000 per cubic centimeter. Clopidogrel is the most widely used P2Y12 inhibitor, and we give it in a loading dose of 600 milligrams. It is a prodrug, and the activity of clopidogrel depends on the phenotype, genotype, and the other co-administered drugs. And in this country, we have demonstrated that about 40% are partially resistant to clopidogrel because of the genetic makeup. Prasugrel is another thienopyridine derivative, which has a more rapid onset of action than clopidogrel, and may be used as 60 milligrams followed by 10 milligrams daily. The new trial ISA-5 found that prasugrel is in fact superior to ticagrelor in acute coronary syndromes, the ISA-5 trial, and therefore it may be used, and it is available in this country. Ticagrelor is the one that is very well known, 180 milligrams of loading dose, and this can be combined with aspirin. Even prasugrel can be combined with aspirin, and in fact, dual antiplatelet therapy is what is recommended in the initial stage. Now, the intravenous GP2B3A receptor antagonist, that is the adizimab, and the other agents are now not routinely used. And what we use is, in this country, the loading doses of aspirin plus clopidogrel or aspirin plus clopidogrel. Now, the use of antiplatelet agents with morphine, I initially spoke of this. Clopidogrel, ticagrelor, prasugrel, the action, drug-drug interaction has been recorded with morphine, so that the action of the antiplatelet agent is retarded when you use co-use with morphine. So morphine use should be reduced. The ESA-5 REACT trial, the study of acute coronary syndromes, both STEMI and non-STEMI. The primary endpoint was 9.1% in ticagrelor, 6.8% in prasugrel, indicating that prasugrel is superior to ticagrelor in the acute coronary syndrome scenario. Now, that is the antiplatelet, but we know that after the platelet thrombus, a fibrin thrombus forms, and therefore antithrombotics has been used. Now, unfractionated heparin, the evidence is very good, but nowadays what we use is enoxaparin. Though it may not be superior to the unfractionated heparin, it is easier to use and no monitoring is required. The body weight can be used as the guiding principle, and therefore we use it. Now, which low molecular weight heparin should be used? We will use enoxaparin. Dalteparin and the other low molecular heparins are not administered in acute coronary syndrome because they have not shown to be superior. How do you administer low molecular weight heparin? You can administer it subcutaneously, but in acute coronary syndromes, it is now recommended that half of that dose should be given intravenously. So you give 0.3 milligrams per kilogram of enoxaparin intravenously, and then subsequently you administer 0.5 milligrams of enoxaparin intravenously, and then 0.3 milligrams of kilogram is administered subcutaneously, and the full dose is repeated in 12 hours, totally as subcutaneous. Now, once you have done all this in the general management, you come to the specific management. You have to cause reperfusion. And what are the reperfusion strategies that we have in acute coronary syndromes? Which of the acute coronary syndrome will need cath lab intervention, and what time limits should be followed? Now, STEMI and very high risk unstable angina both need what is called primary PCI. Traditionally, it was thought that only the STEMI needs primary PCI, but now we have changed the guideline, and very high risk unstable angina, not high risk, but very high risk unstable angina, also needs immediate catheter therapy to open up that artery. So the guideline has changed last year. Now, the 2015 ESC guidelines gives the criteria of what is called the very high risk criteria of non-ST elevation myocardial infarction. If there is instability, hemodynamic instability, or cardiogenic shock, the blood pressure is dropping, or the patient is going into heart failure, recurrent or ongoing chest pain, refractory to medical therapy, life-threatening arrhythmias, that is VT, mechanical complications of myocardial infarction, that is mitral regurgitation or VSD murmur, acute heart failure, that is the flash pulmonary edema, and the recurrent dynamic STT wave changes, particularly with intermittent ST elevation, which comes and goes. These are very high risk criteria, and even if one of these is present, the patient needs immediate catheter therapy. Now, the intermediate risk is diabetes, renal insufficiency, injection fraction less than 40%, post-infarction angina, etc. But we will not go into those details. Now, the reproduction strategies, we have three. We can go in for primary PCI, we can have what is called the pharmacoinvasive therapy, and we can have fibrinolysis. Now, when reperfusion is done early in the course of STEMI, patients do not show a rise in troponin and have only a transient ECG changes, which is known as aborted MI. That is, the myocardial infarction can be stopped. That is, if reperfusion is done very early in the clinical course. Now, timely delivery of reperfusion therapy, whether pharmacological or mechanical, with STEMI is most important than the choice of therapy. So don't worry about doing primary PCI. If primary PCI is getting delayed, then pharmacotherapy or pharmacoinvasive therapy is what is necessary because we must not lose time. Time is said to be of muscle. Now, timing of invasive strategy was stemming. Now, the early invasive strategy is where you can do it within 24 hours. Invasive strategy is less than 72 hours, and the selective invasive strategy is after 72 hours. Remember these important time limits. FMC, the first medical contact to reperfusion must be less than 120 minutes, that is 2 hours. The first medical contact to reperfusion is less than 120 minutes. If the patient comes to the hospital, door to device in a PCI capable center should be less than 90 minutes. And if it is not PCI capable, the door to needle time must be less than 30 minutes. So these are important time limits which the treating physician must adhere to in order to save the patient's life and muscle. Now, it is well known that total ischemic time is the most important criterion which results in improved outcome in STEMI patients. Now, there are certain drawbacks of shortening door to balloon time, because if you don't do it and you take unnecessary patients to the cath lab, you can find that you are doing unnecessary therapies and therefore it will not. In most peripheral hospitals, it will be thrombolysis, which can be administered very, very easily. Thrombolysis is easily available, economical, and evaluated in several clinical studies, but fraught with the dangers of reocclusion of the infarction-related area. This is because when you dissolve the clot, you expose the ruptured plaque to the circulating platelets. And unless you have a good antithrombotic process ongoing, on that exposed ruptured plaque, a thrombus can occur again, though you have lysed it. You have lysed the clot and you have exposed the clot, the underlying plaque, which has ruptured, and therefore this is the problem with thrombolysis. If you get thrombolysis within 1 hour of symptoms of onset, the benefit is great. In fact, the benefit may be as good as primary PCI. We have the term fibrin-specific thrombolytics, and we have the non-fibrin-specific thrombolytics. Now, what we recommend is the fibrin-specific thrombolytic agent, which is tenecteplase. Now, after you give tenecteplase, the clot is lysed and the ruptured plaque is exposed. Unless you give low molecule heparin for the index hospitalization, another clot can occur on that ruptured plaque. And that is why it is not enough to give only for 3 days. The enoxaparin must be continued according to the new guidelines for the index hospitalization. That is 5 days for inferior infarction, 7 days for anterior infarctions until the patient is discharged. And that is what will prevent reinfarction of the patient. Now, contraindications thrombolysis, you all know. I will not go over that. There are absolute and relative contraindications, but there are also non-contraindications. Remember, if the patient is having menstrual cycles, you can give thrombolytics. There is no contraindication. If the patient has had acute ischemic stroke within the last 4.5 hours, still it can be given, and in fact, it is indicated for these patients. If the patient is on warfarin sodium, if the INR is less than 2, it is not a contraindication for the use of thrombolytic agents. A blood pressure below 180 by 100 is required, and if it is higher than that, nitrate infusions are the best drugs that you can give to reduce the blood pressure. How do you administer tenecteplase? You first administer the anticoagulant, 30 milligrams of enoxaparin IV. I hope this has been done. And then a few minutes later, the bolus of tenecteplase is given. In the elderly patient over the age of 75 years, you can see the kilogram-related dose of tenecteplase which I have given in this slide. Half dose is also recommended by clinical trial evidence. Once you give the thrombolytic, bleeding can occur. They can be minor bleeds and major bleeds, and you have to curve it. But remember, there can be overt bleeding. You may not see the bleeding. The bleeding may be to the gut or into the posterior muscles where the bleeding is not seen. And this you can only detect by looking at the conjunctiva and do the hemoglobin assessment to see whether there is overt or latent bleeding. Now, failed thrombolysis can be diagnosed by persisting or worsening chest pain or the less than 50% resolution of ST segment elevation. And in that case, you have to go in and open that artery by a mechanical means, catheter based. Now, primary PCI is defined as emergent percutaneous catheter intervention in the setting of STEMI without previous thrombolytic therapy. Now, this is possible in the PCI capable centers, but not possible in most peripheral hospitals in this country. Therefore, primary PCI is available, if available, and you have a 24-hour service, it is very good. But if not, what we now recommend is what is called the pharmacoinvasive strategy. Now, in this strategy, all patients who come to these hospitals with acute myocardial infarction, which is confirmed, will receive early thrombolysis as soon as possible within 30 minutes, followed by a rescue PCI for failed thrombolysis or non-urgent coronary angiography within 3 to 24 hours. Now, after you give a thrombolytic agent, if you wait for 3 hours and do the angioplasty, the bleeding complications are less. And if you do it less than 24 hours, the myocardial salvage is greater. Therefore, the pharmacoinvasive strategy, the PI strategy says early thrombolysis with tenecteplase, but Indian studies are there with streptokinase also. So if you don't have TK, give the SK. And then transfer to a PCI capable center within as soon as possible, but they can do the PCI within 3 to 24 hours. So the PCI performed 3 hours after thrombolysis precludes the early prothrombotic phase so that enoxaparin continuation does not become warranted, and therefore the patient is on a better. Now there is a trial, the STREAM trial, this is the safety and efficacy of pharmacoinvasive strategy versus primary PCI in patients presenting with STEMI, published in the New England Journal of Medicine. And it gave that if you do this pharmacoinvasive strategy as compared to primary PCI, the results are comparable with even less intracranial bleeding and giving similar outcome. So this is an excellent treatment strategy for third world countries such as ours, where cath lab facilities and helicopter transfer of patients to PCI capable centers is not available. Now, the combination of lytic therapy and PCI, the so-called facilitated PCI, has not been shown to be clinical benefit. In facilitated PCI, the PCI is done immediately after thrombolysis, and this gives excessive bleeding. In the pharmacoinvasive strategy, you wait for 3 hours and you do it 3 hours later, but within 24 hours. So this has been tried out and studied in the Tamil Nadu STEMI trials, and they have shown that in the Indian population, taking streptokinase, the pharmacoinvasive strategy gives excellent results, whereas standalone thrombolytic therapy had a 0.9% mortality, 9% mortality, which is the 10% that we usually talk about. The pharmacoinvasive strategy, you reduce it to 1.7. So from 9 to 1.7, the mortality is reduced, and you can see the benefit that we have for these patients. Now, for lack of time, I will not go into the protocols in detail. Remember that time is muscle. And therefore, in the pharmacoinvasive strategy, we save muscle and we open up the treatment possible for these patients to all peripheral hospitals. I thank you very much.